So it's a great pleasure for me to introduce a longtime colleague of mine, Donna Ames. Professor Ames is a professor in residence at UCLA. Her research has focused on schizophrenia to begin with, and she works out of the Greater Los Angeles VA or West Los Angeles VA Medical Center. And more recently, she became interested and has done some research on moral injury and spirituality in veterans. So she'll talk to us about this very interesting concept. I have to say, I don't think it's only related to veterans' experience or combat exposure, but the entire country. Because a lot of the pathology or kindness or whatever are tied to shame, being ashamed of some experiences of yourself. Some of it is perpetuated by religious teachings. So I think you're speaking more globally than just about VA experience. Welcome, Dr. Ames.
Hello, it's truly an honor to be here today and speak with you. And I've been kind of on a personal journey, I think, to get to this point in my life and career to be studying this, that maybe I'll share a little bit of that personal story as part of what goes on today. These are my disclosures. I do research and have been working at the VA Medical Center across the street in West Los Angeles since 1988. And basically, most of my research career, which actually began before 1988, way back in 1981, was in treating people with schizophrenia, one of the most serious mental illnesses that we have. And so most of my expertise in my personal journey in doing work was in first being really interested in psychopharmacology. And I got into medicine and into the treatment of people with schizophrenia at the time where most of the medicines for schizophrenia were just terrible and resulted in a lot of really bad side effects. And I had the good fortune in the late 1980s to begin to treat patients with newer medicines. For those of you who may be familiar with the field of psychiatry and some of these medicines, these second generation antipsychotic medications, sort of a parallel to first generation penicillins and second generation. These second generation medications didn't seem to have as many bad side effects as the first generation medicines. The first generation medications were really universally hated by our patients with schizophrenia. And lo and behold, the second generation medicines started to be accepted and used, and I was involved in clinical trials on all these medicines. Now, one thing you know about any medicine, they all have something. Something good, something bad. So guess what? The second generation medications had some bad stuff too. Since I was one of the first people working with them, turns out they caused a lot of weight gain, diabetes, problems with liver function, dyslipidemias. And so I started getting really interested in since my patients were doing so well on these medicines and their schizophrenia symptoms were getting better, they weren't hallucinating, they weren't they were more able to function and get back to work. How could I help my patients who had gained all this weight really lose the weight? So I started going into really working on my patients' nutrition and exercise. I started doing research on yoga and integrating that into the treatment of patients with mental illness, dance. I wanted people to have a holistic approach. And so I worked for 10 years running a program called the Psychosocial Rehabilitation and Recovery Program. So I learned about the recovery model for mental illness, which is different than the medical model. recovery says people can get better, even if they have a really serious mental illness, and they can live a meaningful life. I believe you've heard from one of the speakers today about Viktor Frankl and the importance of having a sense of purpose and meaning. So I believe when we work with human beings, we ought to embrace that, and we really got to look at their strengths and help them with their recovery. So in running the Recovery Center for 10 years, I ran into people not just with schizophrenia, but with very debilitating post-traumatic stress symptoms as well, post-traumatic stress disorder. And currently, the treatments for post-traumatic stress that are accepted by the psychological and psychiatric community at large they help, and they're what we call evidence-based treatments, but only 20 to 30% of people fully recover using these evidence-based psychotherapies, which are generally one-on-one. And we have only 10% of patients really getting those evidence-based therapies. It requires a lot of training. There are a lot of barriers to getting every single individual with post-traumatic stress disorder a one-on-one therapist. So we really need help. We really need other things, other modalities, other ways to think about post-traumatic stress disorder to help our veterans. And since the VA has mandated that we embrace the recovery model, I really like the recovery model because it basically, again, it has the notion that everybody's life is valuable, no matter how ill they are, at what point on the spectrum of mental illness. And that basically the recovery model is holistic. And I believe when you look at a person, when they enter your room with a serious mental illness, I believe in an approach which is holistic. And I've written about this. I have some chapters and articles published on what I call the biopsychosocial spiritual approach for treating human beings with mental illness. And over the course of the years of working with veterans in the Psychosocial Rehab and Recovery Center, we started to try to implement therapeutic lifestyle changes, TLCs. And these are all evidence-based treatments, actually, that do as well as antidepressants, exercise, nutrition and diet, spending time in nature, encouraging recreation, relaxation, stress management, religious and spiritual involvement, and community involvement and volunteerism. Roger Walsh, he's at UC Irvine, he wrote an opinion piece that all psychiatrists should be prescribing this. And I've really taken Roger to heart, and when I read this article, it was like 2011, we just started doing it. We started, like every patient, we got to work with these. This is great stuff. This is holistic. It's right on. And we implemented classes at our Psychosocial Rehab and Recovery Center on TLCs, taught by my husband, actually, who's been a colleague and helper in all this in this work. And we started teaching TLC classes to the veterans, and then trying to work with them to develop goals in these different areas of their life. And then I don't get a lot of time when I see patients. I have about a half an hour. So with every patient I see. And so I like to have scales that are really short and concise. So my husband actually came up with this scale, biopsychosocial spiritual scale. And we started using this with our patients in our clinic. And then I started testing it in research and using it in a variety of research studies. We used the biopsychosocial spiritual scale, just 4 really simple statements, to see how our yoga program was helping. And I also have the honor to have Nancy Muller here, who's the yoga instructor who worked with me to develop a really nice yoga program we call breathing, stretching, relaxation, for our veterans with serious mental illness. It could be done by people with any body, shape, form, seated. And we found that yoga was helpful, and using the BPSS. And then I had several grants to try to help people with mental illness lose weight. We had one study called the Management of Antipsychotic Medication Associated Obesity, and we gave the BPSS to everybody in that study. We wanted to see, you know, as they started to do more things, how, you know, exercising more nutrition, will we have any movement in the biopsychosocial spiritual scale? And so during this weight loss study, which was mostly exercise and nutrition for patients with serious mental illness, we started to ask the patients in the study how many TLCs were they doing. Now, if we went back to that list, right, and if we all look around at ourselves, how many of us are doing good things in each of these 8 things, right? So we started just asking our veterans who are in the weight loss study, how many of these things are you doing? At every visit, we just asked. Our nutritionists were mostly focused on making goals for exercise and nutrition, but they just asked these questions. And we asked them to record how frequently they did those 8 things. And we analyzed the data. And what we found was that the more TLCs the veterans in our weight loss study were doing, guess what? The more weight they were losing. That was kind of interesting. I mean, I really think that when you try to lose weight, it's more than just exercise and nutrition. I mean, it's your whole psychological, what's going on with you. Because if you're going through a divorce, that Haagen-Dazs ice cream looks really good, right? I mean, we can't just focus on exercise and nutrition. We have to look at the whole person. So it's interesting that we found that the people doing more of these 8 things were getting better, losing more weight, and they were also improving on the biopsychosocial spiritual scale. So that was encouraging. This is just pilot work. But if you think about it, some of you are in my shoes in this room, and we see patients so quickly. We have so little time. We have to cover so much. We're on the computer trying to fill in all the right forms. But if, you know, just asking a person about these areas, if you can't ask them about all 8 things, just being able to ask them about their well-being in those 4 domains is really important. And I think other speakers have spoken to the importance of looking at the spiritual health of the people that we work with. So we did a second study where we actually developed a workbook and provided groups to teach veterans about therapeutic lifestyle changes, which included a segment on spirituality, and set SMART goals on each one of those areas with the veteran. A SMART goal is specific, measurable, attainable, realistic, and time-bound. So anytime you set a goal for yourself, it would be best if it's a SMART goal. So we work with our vets on that. We asked them to keep diaries of their TLC behaviors, and we looked at the impact of the 8 behaviors on the biopsychosocial spiritual scale. And this is probably very hard to read. But the bottom line is that the journals showed significant increase in TLC practices over time, with an average increase of 2 positive wellness behaviors per week. We saw quality of life improvements for the patients, using a validated scale for quality of life, the World Health Organization Quality of Life Scale. And we also saw a decrease in diastolic blood pressure while the patients were involved in our project. This was, again, just a little pilot study of implementing these wellness kinds of behaviors in patients with serious mental illness. So in conclusion, the classes and the individual coaching really helped increase healthy behaviors in this population. They helped with improvements in quality of life and decreases in blood pressure. This is a little sheet of paper that I actually give every veteran who walks in my office. I am in a very busy clinic. I have probably over 500 patients. And I think that this is really a helpful discussion to have with vets to make sure they are, see where they are on doing these healthy things and trying to set some goals. You don't want to overwhelm people necessarily and say, okay, you got to do all 8 of these. But sometimes let's just start with one thing. And I'm very, very curious and interested in their spiritual life and whether or not they have any religious or spiritual practice. I don't try to put any pressure on anybody there, but I want to know where they're at. Especially, there's been a rather large study of nurses over time. And this nurse study followed nurses for 30 years. And we saw in this study that the nurses who were atheists, who had no spiritual or religious practice, had a 5 times greater suicide rate. We also know, because one of the main things that we have to do when we see patients at the VA is we have to assess for suicide risk. So if I know a person has some kind of spiritual life, I mark that as, okay, that's good. That's good. That's a good thing. It's the people who come in and say, no, I don't believe in God, nothing. I don't go to, no, I used to. Those guys are really worried. And we know that faith can be a protective thing against suicide. And in the VA, 22 veterans, not in the VA necessarily, but today, as of 2013, 22 veterans kill themselves a day. And in the United States. And I saw a movie called Project 22, and I met the 2 young men on the motorcycles in this movie. One was going to blow his head up with a gun, and then he called his friend, and he came out from one side of the country to the other, and stayed with him, and he didn't kill himself. Then they went around the country on their motorcycles, making people aware of this terrible problem. Now, this does not mean people within the VA. These may be people who never made it to the VA or didn't ever seek out any mental health care. So why is that? Why are these young men killing themselves? Or even older men? Why the drive to commit suicide? Now, I gave a talk recently to the physical medicine department at the request of the head of the residency for that department. And unfortunately, another set of people who are killing themselves with great frequency, which may actually be exceeding, as what I understand, the rate with veterans, are doctors. So what is it? Why would people kill themselves? Why would a doctor kill himself? Why would a veteran kill himself? So in my work running the Rehab and Recovery Center, I had partnered with the head chaplain of the VA, and we started a spirituality group for the seriously mentally ill veterans who came to our program in conjunction with different other psychotherapy groups. And the head chaplain called me up one day and said, I have this fellow who wants to do some research. He's from Duke University. He studies religion and spirituality, and he wants to study moral injury. And I was like, I don't know what moral injury is, but I'll try to help you, chaplain, because I want to help the chaplains out. And he goes, I don't know how to do research. And I said, I know how to do research. So what Dr. Koenig, the gentleman who called my head chaplain, wanted to do was develop a scale to measure this phenomenon called moral injury. Now, the chaplains are pretty ahead of the game. They've heard of moral injury. They know about it. Nursing, I think, knows about it. But I've actually spoken to people in high places in psychiatry, and very few people have even heard the term. There's an app that medical doctors use. It's called Up to Date, where you look things up. Like every medical student, what's the right dose of penicillin? Up to date, tells you. I put moral injury in there. Moral injury didn't come up. Medical doctors don't know about it yet. Or at least whoever writes Up to Date doesn't publish anything in there about moral injury. So this is like kind of a newish field for, I think, doctors to be learning about, psychiatrists, and we need to spread the word. And I think it's not only because veterans are suffering from this thing, but I also think doctors and even nurses and even chaplains, I think all of us might encounter this. And as Dr. Lavretsky said, I mean, there are things that happen in our lives where we feel really bad about things we did do or didn't do. You know, as a doctor, you know, one of your patients commits suicide. You're not sleeping. You're upset. You know, if you're, you know, a mistake happens. I will be mostly focusing on the research we're doing in veterans, but this actually is very wide application to non-veterans, to civilians, and probably one of the things that's closest to moral injury in veterans from talking with William Nash, who's a real expert in this area, is possibly the loss of a child. And not being able to have prevented the death of that child. So anyway, these are the definitions that are out there for moral injury: perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. A betrayal of what's right by someone who holds legitimate authority in a high-stakes situation. A deep sense of transgression, including feelings of shame, grief, meaninglessness, and remorse from having violated core moral beliefs. So sometimes moral injury is called inner conflict, and it's described, am I doing the feedback thing? And it may occur in the setting of having to make a choice between two outcomes, such as sacrificing few to save many. And I saw the movie Dunkirk, and in that movie, Winston Churchill had to make a terrible decision between allowing 3,000 troops to die in France in order to save 300,000 in Dunkirk. He had to make a choice. Moral injury can occur when you make such a decision or witness someone in authority making such a decision. So I'll give you sort of the philosopher's way of testing this, and I think people at University of Colorado are doing brain imaging now in this work. There's this thing called the trolley dilemma. So you got a trolley coming, and you're standing by a switch, and the trolley is either going to hit one person or 5 people, depending on what switch you pull. So most people looking at that situation would say, what? What would you do? We'll sacrifice the one to save the 5. And, you know, it's just a switch. Okay, it's a switch, and what can I do? I'm just trying to help out here. Now, here's another picture that they show people in tests and look at their brain scans and do some interesting tests on this. Here's a gentleman who's on a bridge with another gentleman, and there's 5 guys on the track, and the trolley's coming to them. So in this case, what are you going to do? Here, what's your solution? Do you push this gentleman off? Because he's kind of big, and he might actually stop the trolley from killing the other 5. They purposely draw this fellow as a big guy who might be able to just, with his weight, stop the trolley. What would a person do? I mean, it's a terribly, terrible decision to make, and most people are like, I can't do that. Why would I push somebody? You know, So that's kind of an example of making a decision that's painful and horrible. And I actually showed this to one person who said, I would jump off the bridge. So, moral injury model, this is Dr. Koenig's model. And his model is that events happen, killing, violence to others, witnessing violence, not protecting, put in a morally compromising situation. And then you have this inner conflict or moral injury, which results in guilt, shame, self-condemnation, feelings of betrayal, difficulty forgiving, loss of trust, meaning, hope, spiritual struggles, and loss of faith. And then the mental health outcomes are PTSD symptoms, depression, anxiety, substance abuse, sleep problems, relationship dysfunction, pain, various physical problems. We know the mind affects the body, and the body affects the mind. And I can't think of somebody who isn't suffering these kinds of things who comes in my office without a significant physical pain problem. It's almost hand in hand that I see this. And Dr. Sarno, who many of you might know about the mind-brain solution for back pain, he talks about this, that, you know, these deep psychological things that we've gone through. Actually, my brother, who happens to be here, told me about Dr. Sarno and how helpful he could be once we realize, what are we angry about? What is going on that's causing this physical pain in our body? And when you talk to people with physical pain, they'll say, I'm not angry, no. You know, but it requires a little more digging, talking, listening. So moral injury is not necessarily PTSD. Persons with PTSD may also suffer from moral injury, but persons with moral injury may not necessarily have all the symptoms of PTSD. The presence of moral injury may complicate the recovery from persons with PTSD, and only receiving treatment that's focused on PTSD and resolving MI may also improve PTSD or make it more amenable to standard treatment. So for those of you who are familiar with, you know, some of the symptoms of PTSD, this doesn't show everything, but when we think about PTSD, we think about people having nightmares, flashbacks, avoidance, emotional numbing, hyperarousal, loud noise, and my people with PTSD are going to jump out of their chairs. Okay, and I was actually in a life-threatening car accident with my two parents, who I feel blessed to have here today, and to this day, you know, a little bit of a loud noise might make me jump a little bit. But moral injury, we think about shame, guilt, betrayal, moral concerns, and spiritual distress. So, as I said, this is kind of a new area. Like 2 years ago, there wasn't even a scale to measure moral injury over time. And if we were trying to do something for people, how can we measure that it's getting better? So this is what's been evolving over the past couple of years. Instruments have been developed to measure the presence of a morally injurious event in a person's life. Dr. Nash developed the Moral Injury Experience Scale. There's some researchers in Israel who studied moral injury too, and also look at the impact of different types of killing in war. Because in war, sometimes you have to shoot civilians or kill civilians because you don't know where the enemy is embedded, or you have to shoot a combatant who's about to shoot you. There's different forms of killing, and that affects people differently. And there's a Dr. Groves at Haifa University who is looking at the impact of different kinds of killing on the experience of human beings who do that, or have to do that. Instruments have been developed recently to measure the symptoms of moral injury and their change over time. And so we have developed, or Dr. Koenig has developed a scale that looks at these items for self-condemnation, difficulty forgiving, inner conflict over moral concerns, feeling of betrayal, guilt, shame, loss of meaning, purpose, and loss of trust. And this is what the literature is supporting as, so this is not just what we're measuring in our scale, but this is what the literature is supporting most often happens, the psychological sequelae of a morally injurious event. So the other consequences of moral injury and PTSD are anger, depression, anxiety, legal disciplinary problems, physical disability, substance use problems, increased suicide risk, relationship problems and social withdrawal, legal disability, I did it twice, sorry, physical disability, okay, yeah, you guys are sharp, you caught it, cut and paste problem. All right, well, at least you didn't, you came back after lunch, so thank you for being here. All right, so these are the measurements for moral injury event scale, the moral injury questionnaire, military version, and the ones that I've been involved in developing are the moral injury symptom scale military version. And because I'm really pragmatic and a clinician most of the time, I said, Dr. Koenig, this moral injury scale is really long, 45 items. Let's do a short one. So we've come up with a short one that's only 10 items. Yes. Okay, and expressions of moral injury scale, that's another one. So we had 570 patients, veterans, take this, fill out the scale. Veterans were chosen between 2016 and 17. They had PTSD symptoms and were asked to fill this out to see the presence of moral injury. We found a high prevalence of moral injury using Dr. Koenig's scale, and we found nearly 90% of the folks had some aspect of moral injury. And then we also asked the veterans, would they be interested in treatment for moral injury? Because most of the treatments don't necessarily address moral injury. And this is the main components made up of 45 items. Again, guilt, shame, moral concerns, religious struggles, loss of religious faith or hope, loss of meaning, purpose, difficulty forgiving, loss of trust, self-condemnation, and betrayal. This might be kind of boring. This is like the statistical stuff you say about scales. But basically, we needed to show that the scale was valid and reliable, and the scale was found to be, and these are some of the statistics on how the scale was valid and reliable. And then we also did the short form. We looked at the 45 item scale and were able to come up with 10 items. And we also found this was very helpful and might be a good way if you're pressed for time, you don't have time to do 45 item scale. This highly correlated with the long form. And here are the 10 items on the short form. I feel betrayed by leaders who I once trusted. Now, these are being given to veterans. But imagine if you're a healthcare worker or somebody who, works for, another form of industry, and your leaders make decisions that you don't agree with. You see, Dr. Koenig is now working on a scale that will be for civilians. And I think there's really high, he just published a book. I'm a co-author with him on this, and we have in development this civilian scale. I feel guilt over failing to save the life of someone in war. I feel ashamed about what I did or did not do during this time. I'm troubled by having acted in ways that violated my own morals or values. Most people are trustworthy. I have a good sense of what makes my life meaningful. I've forgiven myself for what happened to me or others during combat. All in all, I'm inclined to feel that I am a failure. I wondered what I did for God to punish me. Compared to when you first went in the military, we asked them, has your religious faith weakened or strengthened? So in the future, I'm interested in looking at how moral injury might result in relationship problems. And certainly there probably are events in people's lives within relationships that might lead to moral injury. Say you're betrayed by a trusted loved one. So it is my belief that we're spiritual beings and that we're all struggling with relationship problems. And Glasser was a VA psychiatrist who thought that everybody who walked in his office was having a problem with some kind of relationship. So are we having problems with the relationship with ourselves, self-loathing, which is a part of moral injury, self-condemnation? Is there a problem in a relationship with others, friends, family, work? Is there a problem with a relationship with God or higher power, a sense of purpose or meaning? Spiritual struggles. And how do these relationship problems then affect the soul, the mind, the will, the emotions? So my husband came up with this idea, and we're going to hopefully test this soon, but thinking about a person, a spiritual being going through life in three dimensions, simple as X, Y, Z. On a scale of 1 to 10, what is your health in your relationships with others? What is your health in relationship with yourself? And what is your relationship with God or your higher power? Because when you have a person and you don't have a lot of time with them, you can find out where they are really quickly on these 3 questions. That will really help get to a source of a lot of the suffering that you're seeing in the room. And we're toying with what questions to use here, and we may be changing these, but this is for future, so this has not been published yet or studied. But I just wanted to share these thoughts with you and where this might be taking us next, to look at relationship health in these 3 dimensions. And I am not a specialist in palliative care or any of that, but I've had the honor of listening to some of the other speakers, and I do feel that as a person gets to the end of their life, they are trying to reckon with different relationships, with self, with others, and I lost track. Higher power, there we go! Sorry. Boy, I didn't have lunch because I was too nervous. All right, but anyway, so when people get to the end of life, they may be struggling with those things, but that's what we're all struggling with in the middle of life, right? And so we can start with our young veterans coming out and find out how we can help them and enjoy their life and be in the present moment and suck the marrow out of every day, man. That's the great way to go. So I asked Dr. Koenig, I said, Dr. Koenig, I think this moral injury might be one of the reasons why people are committing suicide. So we looked at that with the 570 data set and certainly found that there was a very high correlation between suicide risk and moral injury. And we just published the paper, so it's not on my reference list, but if you want the paper, email me, I can email it to you. So I would like to see the VA, and I'd like to see this more screening for moral injury, not just at the VA, of course, but I think even within residency programs for medical doctors, within nursing programs. We've really got to keep track of each other and encourage each other. So Dr. Koenig and colleagues and me have looked at moral injury and spirituality and religiosity. and basically found an inverse relationship to PTSD symptoms. And basically, religiosity, spirituality positively correlates with post-traumatic growth. In our study, 90% of veterans with PTSD reported the moral injury symptoms as well. And overall, religiosity was inversely related to moral injury in veterans with severe PTSD. So another thing that we think about when we see that big number, 22 veterans killing themselves, why is that happening? Some veterans don't want to come to the VA. They don't want to associate with or have the stigma of being ill. And some of our veterans would rather maybe seek out help from a clergy in the community. It's a lot less embarrassing if you're living in a small town to go to church and maybe help out there and get some counseling there than to pull into your local VA or mental health center. So I'm really interested in, I'm talking with chaplains about how we can get moral injury knowledge into our communities, to chaplains working with people in the community to recognize this. And I really truly believe in the importance of partnering with chaplains and clergy in the community on this problem. So some of our veterans actually may prefer chaplains, and we actually asked the question, would you rather talk to a chaplain or a secular psychologist on the matter of moral injury? And 80% were open to some kind of spiritually oriented treatment. In terms of the veteran population, there tends to be a high level of spirituality or religiosity amongst veterans. And so this is really why I think we need more chaplains and more, ability of psychologists, social workers, and psychiatrists to be really spiritually dialed in and help out veterans. Specific interventions that are in development are listed here. There's something called adaptive disclosure. There's another form of therapy called impactive killing. Another one called acceptance and commitment therapy. I like that one. I've used that in my recovery work, where you learn to accept yourself and accept your symptoms, but you keep moving forward. You don't get mired in the past. They're starting to use this with people who are suffering from moral injury. There's a really neat study that was just published by, I believe, Irene Harris on building spiritual strength, which is a work with chaplains and therapists together to help veterans. Hope I got that right. My chaplain friend here. And then what I'm developing and testing at the VA in West Los Angeles, God willing, spiritually integrated cognitive processing therapy and chaplain interventions. Now, spiritually integrated CPT, for those of you who don't know, CPT, cognitive processing therapy, is the evidence-based treatment that the VA feels is most important to get to our veterans. But this is one that's spiritually integrated and uses the veteran's spiritual background as part of the therapy. And right now we're going to be testing that in folks using psychologists to give that, and then hopefully be able to train chaplains. And then we came up with another intervention right now too, just a chaplain intervention. And we developed workbooks for 5 of the major religions for the chaplains to use. We have Christian, Jewish, Buddhist, Hindu, and Muslim versions of these. And we have 5 for the spiritually integrated CPT. The structured chaplain intervention is 12 50-minute individual one-on-one pastoral care sessions with the veteran. And it's The intervention's designed specifically for those who indicate that religion's important in their lives. It's to be adapted to the specific religious beliefs of the veteran. And the contents of the chaplain intervention include these items: guilt, shame, betrayal, moral concerns, loss of trust, loss of meaning, self-condemnation, difficulty forgiving, religious struggles, and loss of religious faith. As a caveat, I'll mention I teach anger management classes. I have about 45 angry people in my class every week, and I love it. I love teaching, it's really fun. And I think one of the biggest problems that people have with anger is a lack of forgiveness, right? They're so angry at whoever did this to them. They're in this like constant state of, I'm a victim, and they did that to me, and I'm here because of that. I really think forgiveness, that is what we have to work on. We got to forgive ourselves for doing some bad stuff. We got to forgive our parents or the military or the boss who assigned you to this crummy thing you didn't want to do. We got to forgive. And then we got to forgive God or our higher power who's really messed us up. So, whatever. We got to forgive everybody involved. So anyway, so when the angry people come in my room, I figured they really need work on this forgiveness stuff. And so I am going to be looking at my 45 people once the IRB approves it to see how many of them have moral injury. I don't know. I just take everybody's angry and they come to my class. The court orders them. Okay, so this is the contents of the chaplain intervention: conviction, lament, repentance, confession, forgiveness, reconciliation, atonement, recovery and resilience, and anger. So we have these modules for the dimensions above, for each of the 5 religions. And then this is a little bit about spiritually integrated CBT. It explicitly draws on a client's spiritual religious resources and addresses the spiritual struggles and moral injuries, spiritual beliefs, practices, rituals, values, and inspirational passages to challenge and change unhelpful patterns of thinking and behavior. Spiritual concepts such as kindness, compassion, and acceptance. Spiritual practices such as confession, forgiveness, making amends, spiritual surrender, prayer, meditation, and spiritual community. And it targets the moral injury to reduce the PTSD symptoms. This has been developed by Michelle Pierce and Dr. Koenig. Michelle Pierce has also written a book on cognitive behavioral therapy that's spiritually integrated. And again, we have 5 religion-specific appendices for this intervention. So we are planning to do a 3-arm study. We're going to compare classic CPT for patients who have moral injury and PTSD versus the spiritually integrated CPT versus the chaplain interventions for veterans. It's a big study that we're trying to do, and it's got a lot of logistics involved. Hopefully we'll be getting to recruit people in the near future. So in summary, in addition to a holistic biopsychosocial spiritual approach, veterans may benefit from treatments utilizing a spiritually integrated approach. Moral injury should be recognized, as it may explain why veterans with PTSD do not fully recover with currently available treatments. And spiritually integrated treatments can foster collaboration between chaplains, faith-based communities, and mental health providers. And research on recognition and treatment of moral injury in veterans and civilian populations needs to continue. I really hope we learn more, and I think the application of what we learn in veterans can be applied in the communities. And I just had a little example here of one of the sacred texts for the theme of forgiveness that we'll be using in our intervention. There's a story of a prodigal son, and he's like a dude who's just done like every bad possible thing. And, you know, the story can be very relatable for our veterans. And even though he's done all these bad things, his dad welcomes him home, makes a big party for him. And so when I think about this story, and I think about other people who work with really challenging people, like Biz and I work with the most challenging people, and I have for 30 years. And there's a fellow named Greg Boyle who wrote the book Tattoos on the Heart, which if you want to cry, read that book, it's amazing. It's amazing. He worked with felons coming out of prison, and he got them all jobs. He runs Homeboy Industries, okay? And his book talks about having this unending compassion for people that just like flows through him. And if we all treated each other with the compassion, mercy, forgiveness, grace, and unending love that the prodigal's father had for him, imagine how much better this planet would be. So thank you for listening.
Any questions, please? Over there. Okay. I'll try to run.
I'll do it. I'll do it real fast. Hi, my name's Milani. You know, you showed us that trolley with the one person and the 5 people. So what happens if that one person was your mom, or that one person was your child? You know, no doubt you know what the decision you would make, and then the moral injury of the 5 people, because those 5 people also have people who love them. Just either way you lose.
Yeah, no, it's a horrible, horrible mind thing. Like if you go online and you type in trolley dilemma, guess where they're applying this? You guys hear of the Google cars? Well, these Google cars have to be programmed. What do you do if one person comes in the street or there's 5 over there? Who are you going to hit?
Right.
I mean, it's a terrible decision.
On Netflix, I was watching The Good Place. I don't know if you've seen it. They actually did this on one of their shows with the blood splattering on the guy's face because he chose that route or that route.
No, and as doctors, you know, or in mental health professionals or any kind of professional sitting in this room, sometimes you have these terrible choices like, you know, I can't take your phone call right now, you know, because I have these other 10 people, and I know you're really important, but I want to talk to you. And then you find out the person got really sick and you forgot to call them back, or, you know, there's all these micro decisions we have to make, and there's constant sense of, am I making the right decision? You know, how do you know? How do you know? What guides you? What keeps a moral compass for you? And how do you really remember what's really important in life? I mean, it took a long time for me to wake up to figure out what's really important. And right now, those people are right there in the row there.
What about the movie Sophie's Choice, where there is no moral choice?
It's a terrible, terrible dilemma. And Sophie probably suffered horribly, and she did. She suffered moral injury. That's a great example. Like, movies can really help us think about some of these issues that, you know, and not just movies, it's our own life, you know. How many times do we make decisions in a day that we feel guilty about or ashamed, or, you know, and we have to realize, you know, life is a series of choices, and we have to forgive. We have to forgive, and it's really hard. Yeah.
So trained in CBT, but also in PD or PTSD?
Yeah, prolonged exposure. Those are the two that the VA thinks are the best.
So I'm just wondering if you know why they're choosing CBT so much over the PD right now.
I'm sorry, I should have made it very clear. The VA actually chooses CPT and PE. Those are considered the best therapies for PTSD. And if you look, you can go online and see what the protocol is for treating PTSD, and it usually involves one of those. That's the top thing. The problem is we don't have enough therapists to do it, and there's so many patients. So what else can you do? And I really believe that if we can get people into like a holistic approach, and what I'm talking about, these 8 TLCs, this could be delivered by many healthcare professionals. I like to get all my nurses trained so that when I got 30 minutes and I have to be writing the prescriptions, they can then do some TLC coaching. And then, would you like to talk to a chaplain? I'm always asking that. Every time one of my vets comes in, I know this sounds weird and you haven't been to church in 15 years, but maybe you'd like to talk to a chaplain. It's just put it out there that some of what you're struggling with might be just bigger than this, or in addition to what you're getting from psychotherapy or medications. They'll say yes, many times.
Hi, Dr. Ames, I just want to really say thank you. This is amazing work. I'm an integrative psychiatrist. I went through residency that was very heavily psychodynamically based and studied all modalities I think that I can. And one thing I early on felt like didn't feel right was how quickly, if your client, if your patient struggles with anger, it's always sadness, that it's a cover-up for sadness. And it took me a while to feel like, no, there's something really different here. And the closest I've gotten to is anger. And now you've given me, I think, the more specific language. And I think that I use a lot of essential oils in my practice. And it's very interesting. Sweet marjoram is very good for anger. And rose is very good for grief. And it's really automatic how well they work if you really guide the person right. And then there are people who have that bitterness, that anger, that moral injury. And when they smell those oils, it's repugnant. And then the ones that I've had success in having them transform that bitterness, the moral injury, 3 months later they will have a positive response to those oils. It's really in their body. And I think the last thing I want to say is I think that it's a cultural problem. It's a societal, who's creating our culture that I think it's really interesting that we have a problem with the idea of authority as something that's meaningful, actually. That we think that authority is automatically something oppressive. When is really what you're talking about, and which I see in people, is that we actually care that the authorities are good, and that we can believe in them, and how powerful that is.
We have somebody here.
I wanted to ask you about the workbooks, the 5 major religion workbooks in the spiritually integrated cognitive processing. So are you actually training chaplains now with the workbooks, or do you want volunteers?
Oh, man. Thank you. Well, basically I have 4 chaplains that we've trained. Dr. Koenig and I have met with them for 8 hours. And I actually brought my big workbook to show anybody who might be interested. It's not tested yet, but I have everything here. I would love to hear from people if you're interested in learning more, or if there's ways that you want to try it out. It's not tested yet. And the way science works, you have to show things work with a study. But maybe if people read it and find it helpful, they could use it. I don't know. So I have it here. And, but basically, I've trained 4 chaplains. I've had the honor to talk to chaplains over 2 years to give input into this. And then I've run into people and say, well, would you like some help? Our chaplaincy could sure use some help. If you want to come volunteer, you could talk to our head chaplain. It would be wonderful.
Yes, I have a question. In terms of helping somebody overcome like grief and some of their problem with just a lot of regrets, for example, one of the things that happen generally, it will affect the person's ability to even have like a normal sleep. And sleep to me is the cornerstone of healing. You cannot heal somebody until you're able to restore the ability, the natural ability to fall asleep, to surrender to sleep. Mm-hmm. That is through my own personal practice as a healer. And that's the first thing I start with. Restore your ability to sleep, number one. Because it is dependent on the quality of sleep results in the ability of restoring the natural healing process of their liver and their kidneys, which are also going to be storing a lot of that, sort of a baggage from, the traumas, etc. So I'm curious to hear more about your experience. What have you used, for example, that you found to be beneficial for that?
So a lot of times veterans walk in my office and they've been through the mill of multiple medications. Insomnia is one of the first things I want to know about. And because I've been getting away from using classic psychopharmacology so much, jumping right to that, I tend to do a number of blood tests to see where my patients are in their levels of magnesium, what their kidney function is, what their liver function is. I get EKGs. I treat the whole person. Then I look for nutritional deficiencies, B12, folate, I'll check vitamin D. And I'll tell the people as they come to my office, I said, I'm kind of a weird psychiatrist, but we're going to take a totally different approach. Are you open to a holistic approach? I'll be like, yes, why didn't I meet you 10 years ago before being put on a truckload of psychopharmaceuticals that have done nothing but cause me side effects? And honestly, with the VA now says that the treatment of PTSD is not necessarily help. First line is not to give antidepressant medication. So what I do is I get these people on my 8 TLCs, and for sleep I'll often prescribe melatonin or magnesium and vitamin D. Most of my vets tend to be deficient in. I get them on vitamin D. I get them eating properly. I talk about the Mediterranean diet. So again, it's a whole holistic approach. And so I want them exercising, you name it. So I totally agree with you. Sleep is key. Most of my people end up having sleep apnea. So I get people tested for that. And I've saved a lot of people from being put on antidepressants by just simply getting them tested for sleep apnea. As a matter of fact, my dad right here. He's cured. All right, well, thank you so much.